Yeah. Okay. Next slide. Next slide. Hi guys, I'm Jamolbi. I got plenty of introduction, so let's just crack on. So starting with the vaginal examination, it's just like any other exam. You introduce yourself, you confirm the patient's name and date of birth, and then you can explain what you will do. So I just put a little blurb here of what you say. Today I need to carry out a vaginal examination, which will involve me inserting 2 fingers into your vagina while pressing your tummy with my other hand. This will allow me to assess the vagina, the womb, and ovaries. It shouldn't be painful, but it will feel a little uncomfortable. You can ask me to stop at any point, and I will. This is just like in the format that you usually explain things to patients, but you could change it and tweak it to whichever way you're more comfortable with. And always after this, you mentioned that there will be a female member of staff present as a chaperone, and they will need to be bare below their waist and take their underwear off as well. And you'll give them a blanket to cover up. You ask them always if they're in any pain, if there is any chance they could be pregnant, are they happy for the examination to start, and do they need to empty their bladder? Because obviously if they have a full bladder, then it would mean you wouldn't be able to palpate things and it would be quite uncomfortable for them. So this is what you do, and while they get ready, you go and wash your hands and don the PPE and everything that we need to do nowadays. Next slide. So when the patient is lying down, you make sure they're lying down flat, and you put them in this modified lithotomy position, which is please lie on your back, bring your heels towards your bottom, and then let your knees fall to the sides. So it's like in a butterfly shape kind of thing. I'm sure you guys done it before. And you, as in every examination again, you start with inspection of the vulva, you inspect for ulcers, abnormal discharge, which could be a sign of infections, scarring from maybe like a previous episiotomy or something, any masses like Bartholin cyst, which is basically a cyst that forms in the Bartholin gland, which secretes the enzymes for keeping the vagina moisturized. And then any white lesions, rashes, and then you ask the patient to give you a cough to check for any prolapse. Next slide. Okay, so now you want to do the examination itself. So you have gloved your hands and you get a lubricant. You lubricate your 2 digits, which is on your dominant hand, whichever, it's mostly right-handed people, but you don't know. So warn the patient that you will now insert 2 digits to examine their vagina and that the lubricant could be slightly cold. So once you've got the lubricant, you lubricate the glove, index and middle finger. You carefully separate the labia with your non-dominant hand. So for me, it would be my left hand. And then you gently insert your fingers in like this. I hope you can see it. And then you turn it up. So your palm was lateral, and then it looks upwards then. And you basically palpate the vaginal walls and then the cervix. So is it in position, like consistency? Is it smooth? Is it irregular? Is it hard? Any tenderness in the cervix? Does it move? Is it immobile? Things like that. And the fornices, which are just on the sides of the cervix. So if you look at this picture, if Ria could point her arrow to the cervix, and then on the sides to the ankles, those are the fornices. So that's where you then palpate with the gloved fingers. Next slide. And afterwards, to feel for the uterus, you put your non-dominant hand again, and you press on their tummy, just like shown on this diagram here. So you place your hand halfway somewhere in between the belly button and the pubic symphysis. And you put your fingers again in the posterior fornix, and you push upwards with your non-dominant, you push upwards with your fingers and downwards with your non-dominant hand. And you should be able to feel the uterus between your hands. And so you comment on its size. They say it's usually about, on average, it's like a size of an orange. I don't know. If you could feel the first, but like the shape, is it anteverted, retroverted? In most females, it's anteverted, so the uterus is like towards the bladder, like seen on this picture as well. So the position again, the surface, smooth, irregular, hard, nodular, things like that. Any tenderness anywhere, either on top, like, or inside. And you always ask for pain, and you always watch the patient face, because sometimes they don't tell you they're in pain, but you see it that they're kind of like just holding it all together. Next slide, please. Okay. And then after you've palpated centrally on the abdomen, I mean in the pelvic region centrally, you palpate the adnexa. So adnexa is the place that contains ovaries and the fallopian tubes. So it's in iliac fossas, right and left iliac fossas, basically. So you position your internal fingers to the left lateral fornix, and you position your external hand onto the left iliac fossa, and then you press again, and then you do the same on the right side, and you again feel for any palpable masses. If you feel something, try to describe it. You try to maybe approximate a size, or like, is it smooth, is it irregular, is it hard, is it soft, does it move, things like that, which you would describe with any mass basically. So you do it on both sides, and then you take out your gloved fingers and you inspect them for any blood or any abnormal discharge. You cover the patient, give them some towels, tell them it's done, and you leave them to clean up themselves. You come out and summarize your findings. So you're going to be like, today I performed a vaginal examination or a bimanual examination of so-and-so patient. She's a 20-year-old lady, presented with something. And then you'd be like, examination was normal or abnormal, whichever case. And then you explain what you found, if you found something abnormal. And then you'd say, to complete my examination, I would do either a speculum if indicated, abdominal exam, do a urinalysis, a urine pregnancy test, things like that, basically. So this completes this part. So let's move on to the speculum examination. Okay. Any questions so far, guys? Well, if you have any questions, just pop them on the chat or just unmute yourself. That will be fine as well. So again, with the speculum examination, you introduce yourself, you confirm the patient demographics, and then you explain. So today I will need to perform a speculum examination, which will involve inserting a small plastic device called a speculum into the vagina. This will allow me to see the neck of the womb and take a sample, a cell sample with a brush if needed. It shouldn't be painful, but it will feel a little uncomfortable. You can ask me to stop at any point. You may experience some light vaginal bleeding after the procedure. And again, you could, change this to your own, in your own way, say it in your own style. And of course, just saying this and having the speculum there is a very good bonus point, because they can actually see it, whereas it's hard for me at the moment to even show or explain things. But yeah, some of them can look a bit kind of thrown off when you see the speculum, but you explain them, you're going to be as gentle as possible. It shouldn't hurt. And if they tell you to stop, you're going to stop. So make sure they're comfortable. And again, mention there will be a chaperone present. You ask again for any pain or pregnancy. Gain their consent. Are they happy for you to move on with the exam? Again, tell them that they will need to be bare below their waist and remove their underwear as well. Lie on the bed. You again tell them to empty their bladder. Gather your equipment. That's again gloves, your lubricant, your speculum, so Cusco device, and the brush with the sample tube if you need to. And when you have everything ready, you move to them. You again put them in the modified lithotomy position with their knees flopped, and you start the exam. Next slide. Okay. So again, I just put inspect the vulva, and I didn't put details because I discussed them before. It's the same thing, guys. So inserting the speculum, you use your left hand, it says index finger and thumb, to separate the labia again. So non-dominant hand, it could be the right, like it depends, yeah? And you gently insert, and you again warn them that you will be inserting the speculum now, and it has a lubricant and it might feel slightly cold, okay? So you gently insert the closed speculum sideways. So if you've guys seen a speculum, and I'm sure you have, the top that's like opens and closes it, that should be sideways when you insert it, basically. So when you insert it, you angle it downwards, because especially when like the patient are quite overweight, it's really difficult to visualize or find even the cervix. And that's why just whenever you start doing it, just push downwards, because usually that's where the external os is seen. So when you insert it in a downward angle. And once you insert it, you could rotate it like upwards. So the part with the screw is on top. And you open the blades. So you open it as much as you can, and then whenever the cervix is visualized, basically that's where you screw the little thing on top so it stays fixed. And then you inspect the vagina, the vaginal walls. Are there any warts, any discharges, any masses? The cervix, is the external os open? Is it closed? Are there any erosions, ulcers, discharge, masses? Again, same thing. And then after you've seen and inspected and reported everything, you take your brush, and if you've guys done it before, or if you've seen the brush, then it's angled upwards, and that's angled brush basically goes into the endocervical canal, the angled bit. So you tell them that now I'm going to insert the brush and just swipe some samples. Again, it shouldn't be painful. So when you put the brush, you rotate it 5 times, 360 degrees clockwise, and you take it out. Make sure that it doesn't touch any side of the speculum, and you put it directly in your liquid cytology container, and you lock it off. That's done. Okay, next slide. Now you tell them that you're done with that bit of the examination. Now you'll remove the speculum. You loosen the screw, but make sure that you have your fingers holding the speculum, because sometimes it can just close really fast and it could pinch the patient or something. It could be quite painful. So yeah, you hold it, unscrew, so loosen the screw on top, and then you rotate it backwards into that lateral position. And then you gently remove it and make sure you don't catch any sides of the wall or anything. Then you cover the patient, tell them it's over, and give them some tissues, and dispose all of your equipment in the clinical waste bin. Make sure, especially in exams, make sure you label the samples, any sample that you get, be it bloods, urine, whatever sample, or if it does have like the label on it already, make sure you read it out and confirm that it's the correct person. And then again, you summarize your findings, just like you do for the first examination, saying what you found. Was it normal? Was it abnormal? And if it was abnormal, then maybe for completeness sake, you would do investigations like transvaginal ultrasound or bloods and like things like that, basically. And yeah, this brings us to the break time, I think, Ria.
Yeah, if other people would prefer, we could go on and do have a break before the cases. Would that work?
Yeah, if they would. I think so, because I've rushed through things. They're quite short, these exams. So usually they could give you both exams at the same time because it's just comfortable to do it at that same time. It doesn't take much extra time, I'd say. But like, yeah, if they tell you to do it separately, then you do it separately. But yeah, let's move on then. Let's move on to gynae history and cases. Okay. So gynecological history, again, you do introductions. Okay, and you'd be like, hi, my name is Jamolbi Rahmatova, I'm a fourth year medical student, or usually in cases you're a junior doctor, so I'm a junior doctor. I've been asked to speak with you about what brought you in. Are we able to get the slides later? I think they will be on Study Hub.
Yeah, that's correct.
Yeah, so I will speak to you about what brought you in, confirm their full name, their date of birth. And just because in OSCE stations, I hate this when you have to calculate their age. So I just ask them, and how old does that make you? And if they're nice, they won't make fun of it and just tell you how old they are. And then you will be like, everything we speak about will remain confidential between us and the medical team. Is that all right? Things like that, gain consent. So, and then you always open with an open question. What brought you in? Or how are you feeling? Things like that. And the main presenting complaints, and I said this in my obstetric history as well, but like it's basically 4 P's, just remember them. It's pain, PV bleeding or PV discharge, and pregnancy. Those are the main things in ONG that bring people in. But with gynae history specifically, so pain could be just pelvic pain, general pelvic pain, dysmenorrhea, which is pain during menstruation, and dyspareunia, which is pain when they're having an intercourse. And so PV bleeding, you ask everything about that bleeding. Is it just heavy bleeding? Do they have intermenstrual bleeding? Does it happen post-coitally? Postmenopausal women sometimes could present. And then also like just amenorrhea, oligomenorrhea, things like that. And discharge. So what color is it? When did it start? How did it happen? What maybe order or consistency, and yeah, time frames, things like that. And then pregnancy as well, of course. And for each presenting complaint, you basically establish the time frames. For pain, I'm sure you all are aware, you do the Socrates. And then for any type of bleeding or discharge, you do frequency, volume, color, order. In bleeding, like clots. And you could ask them like how big they are. Is it like a 50p or something like that? And then consistency. And then you ask them about their GI and GU symptoms and red flags, basically weight loss, appetite changes, overnight sweats, fevers, rigors, bleeding from elsewhere, like hematemesis. Are they wanting blood or blood in the urine, blood in the back passage, things like that. And then because they will give you a lot of information, you just make sure that when you're lost, just stop and summarize, just so that there's a flow to your conversation. Just be like, okay, so you've told me a lot and you've been going through a lot from my understanding. Can I just take time to summarize what I've understood so far and let me know if I have missed something, okay? So then you summarize and then be like, is that correct? Is there anything else that I haven't asked you? So because there's almost always some things that you miss, you just ask them that question, and if there is anything, they will tell you. And then you ice them, ideas, concerns, expectations. What do you think it is? What is it that you're most worried about? Do you have anything in mind that could be causing it? Things like that. Next slide. And then, of course, an important part, and just before I move on, guys, I've put it in this kind of structure, but obviously as you go along, it's a bit all over the place, right? The history that you get. So just make sure that you structure it in your head in some way that you're more comfortable with, okay? So menstrual history, you ask when was their last menstrual period, age of menarche, it's usually 13. Are their periods regular, how long they are, and then the heaviness, are they heavy, are they light? So in terms of heaviness, it's a bit difficult to clarify, but on average, I think females lose around 80 mils of blood, could be like 50 to 80 mils of blood in one cycle. And that's, if you think, you ask them how many pads, for example, or tampons have you soaked through, for example, right? And I think one soaked regular pad or a tampon is around 5-6 mils. So you could calculate it that way, maybe. So on average, it's like 6 to 10 regular pads is like the norm. But yeah, everyone is different. So that's just an easy way to, make sure you know how heavy and how much. And then are they menopausal or not? And that's also obviously depending on their age. You ask that question. And a short obstetric history, because these histories always go together. Have they had children before? Have they been pregnant before? How many children do they have? And of course, it's quite a sensitive topic about terminations and miscarriages. So you always signpost at any point, like, what is the amount of blood loss per menstruation? So it's on average around 80 mils. Some could be less. So for some, the norm is around like 60. So it could go from like 50 to 80, something like that. Different papers say different things. So you just formulate your question in empathetic way and just be sensitive. Just be like, this could be quite a sensitive topic, but we have to make sure that we ask this question from everyone. Have you had any previous miscarriages or terminations? And then would you mind if I ask, how did that happen? For example, terminations, was it done medically, surgically? Were there any complications and things like that? Miscarriages, again, the reason maybe, like, why did it happen? Do you know? Things like that. And if they have children, then how was their birth? So was it just normal delivery, no complications? Just a quick run through, basically. And then sexual history. Sexual history is very, very, very important. And in OSCEs, sometimes they could just give you a station of take a sexual history, and that's going to be your main focus of the history because it's quite extensive. But yeah, so you ask them, are you married? Are you single? Do you have a partner? Is it male or female? Never assume, okay? Never say, okay, he or she, whatever. No, just call partner. So your partner, is it male or female? Just make sure you don't assume anything. And how long have you been with this partner? Are they your only sexual partner? How many sexual partners have you had in the last, 3, 6, 12 months? What kind of sexual intercourse do you usually engage in? And again, these are all sensitive questions. Be nice about it, be empathetic, just formulate your questions properly. And then, have you had any previous STDs, chlamydia, gonorrhea, things like that? Do you use contraception? Do you use barrier methods like condoms? If you use contraceptions, what pill, how are you feeling, things like that, right? And make sure, if you don't ask like nothing out of this, just make sure you ask about smear tests, recent smear tests and their results. And then you could ask about contraception or whatever, but just make sure you remember smear tests and results, because doctors love to just point that out all the time. And then just general past medical history. So any gynecological procedures, CS is cesarean section, sorry guys. Any bleeding disorders, malignancy, migraines with aura, any risk of VTE, and migraines with aura because they cannot be on combined contraceptive pill, things like that, basically. Moving on. How am I doing? Okay. And then medications, again, allergies, their pills, regular pills, family history, ovarian, endometrial, breast cancer, so the BRCA gene, any bleeding disorders. I think that's the main thing. And then social history. So what do they do? Where do they live? Do they have any support? So some of them could be a bit worried about like cancer or things like that when they come in. So you make sure that there's someone to support them at home. So how is their diet? How is their weight? Because there always could be an endocrinological thing going on there. So yeah. Are they generally active? Do they smoke? Do they drink alcohol? Do they ever do any recreational drugs? Things like that. And then again, after everything you've gotten, just be like, have I missed anything? Have I maybe not asked you something that you want to tell me? Or just be like, at the end again, just ice them. Any other concern that you have, what would you like to get out of this consultation? Or just be empathetic, guys, and summarize well, so that, because summarizing not only helps you to just fill out that pause and remember things to yourself, but because you summarize it so many times that at the end, when you have to summarize your findings to the examiner, it comes easy to you because you remember all those things, right? So just make sure you do that, guys. And then you end the conversation and move on to the questions that the examiner will ask you. Any questions so far? Okay, I'm just going to answer this question. What is the difference between gynecology and obstetric history? So in both histories, you ask about both things, but in gynecology history, you focus more on gynae stuff, and in obstetric history, you focus more on obstetric stuff, if you know what I mean. Does that make sense? Because when there is like an obstetric history, then there's loads more that you have to ask. Like there's screenings, are they normal, any problems with the pregnancy itself, how their trimesters have been going, and then more detail about their pregnancy before and things like that. Whereas with gynae, it's more focused on, their menstruation and basically the medical bit of stuff, what happened. Okay. Does that make sense?